Well, hello everyone. Welcome to the ICMDA seminars. I'm Philippa Taylor and I'm Director of the Institute for Faith and Culture, and I run a leadership program for young people who want to go into politics. But I'm standing in today for Peter Saunders. Peter and I worked together for many years at the Christian Medical Fellowship, and I had a particular focus on beginning of life issues while working there. So let's introduce Dr. Cirucci. Dr. Cirucci is a board certified obstetrician gynecologist and a longtime member of APLOG. She earned a degree initially in mechanical engineering from Virginia Technology University and worked in the engineering field for 7 years before she pursued a medical career. She got her medical degree from Thomas Jefferson University in Philadelphia, and then completed her studies at the Medical College of Virginia. She then joined a private obs and gynae practice in Pittsburgh, where she worked for 20 years. She's volunteered her medical skills in various third world countries in Africa and Asia, and has made multiple trips to volunteer at a Memorial Christian hospital in Bangladesh. And she has a deep heart for the life of the unborn, and she joined the APLOG board in 2021. So it's my great pleasure to hand over to Dr. Chris Cirucci now. Thank you.
Well, thank you so much for that introduction. Thank you everyone for coming. So as I said, I'm going to be talking about chemical abortion, availability, and complications. Our goals here, I'm going to provide an overview of chemical abortion. We're going to review the research on the complications. I will briefly describe abortion with misoprostol alone, with the one medicine instead of the two. I will discuss the online availability of chemical abortion pills, and also discuss the risks with self-managed abortion. So just an overview of chemical abortion. Now, sometimes this is called medical abortion. Sometimes it's called medication abortion, sometimes the abortion pill. So chemical abortion is typically accomplished with two medications. The first one, mifepristone, also known as Mifeprex or RU486, is given typically 200 milligrams orally. Mifepristone is an anti-progesterone. It blocks the progesterone receptors in the uterus, causing fetal death. Then 1 to 2 days later, the woman takes a second medicine, misoprostol, also known as Cytotec, and this is usually put in the buccal root, which is in the side of the cheek. Misoprostol causes contractions, which expels the baby. Now, in my country, I'm in America, it was approved in the year 2000 for up to 49 days, 7 weeks. And then in 2016, it was approved up to 70 days or 10 weeks. Now, I'll talk about this more later, but the farther along in pregnancy, the higher the risk of this procedure and the less likely it will be successful in aborting the baby. Now, the typical course of someone undergoing a chemical abortion is bleeding and cramping, similar to or greater than a heavy menstrual period. On average, the bleeding lasts 9 to 16 days, but some women, 8%, bleed more than 30 days. And then the woman basically delivers the baby, passes the pregnancy at home or wherever she is. So this is a graph from the Guttmacher Institute, just showing, and this is in the United States, how since it was approved in 2000, medication or chemical abortions now account for over half of the abortions. And I think this number is going to keep increasing, or this percentage. And I don't know the data in other countries, but I would imagine it is similar in many countries. So I want to talk a bit about adverse events or complications from chemical abortion. And we'll go into these in detail, but just as an overview, the most common adverse events are retained tissue, meaning there's still placenta or everything hasn't passed, and this can require a uterine aspiration or a D&C. And that probably the second most common adverse event would be hemorrhage, also possibly requiring a D&C. Other infections would be other complications would include infection, bleeding to the point of transfusion. There have been deaths that have occurred from chemical abortion. The most common reason is infection. Other issues, I want to briefly touch on these two. One is ongoing pregnancy, meaning that the woman is still pregnant with a live baby. That happens in the first trimester about 1% of the time. And another issue, which I will discuss more later, is ectopic pregnancy. So as you probably all know, an ectopic pregnancy is a pregnancy outside the uterus. It's in the tube, and it can become life-threatening and cause internal hemorrhage. Well, these medications do not treat ectopic pregnancy. So if a woman takes these medications and has an unknown ectopic, but she thinks she has an intrauterine pregnancy, then the ectopic is not being treated and can be delayed. I'm going to have a brief discussion about the pharmacology. So as I said, mifepristone is an anti-progesterone. We know that progesterone is required to support a pregnancy. So mifepristone is a selective progesterone receptor modulator. It binds to the receptor in a way that actually acts as an anti-progesterone. So it blocks the progesterone in the uterus. It also has anti-glucocorticoid activity. So mifepristone was actually initially developed for the treatment of Cushing's disease. It blocks the cortisol receptors in the central nervous system and the peripheral tissues. It does have a long half-life, 30 hours, and in some people, 90 hours. Now, it has been associated with a very rare bacterial infection, Clostridium sordelii. And I did mention that the most common cause of deaths has been infection, and the most common cause of those infections is this rare bacteria. It just causes a very fast, fulminant infection that usually results in death. It's rare. And this is the drug insert, and there is a black box warning about serious and sometimes fatal infections and bleeding. So again, this is mifepristone, the first medicine. Misoprostol, which most of you are probably much more familiar with, is a prostaglandin E1 analog. It is actually approved by the FDA to prevent ulcers for those on long-term non-steroidal anti-inflammatory drugs. It inhibits gastric acid secretion, it protects the mucosa, and it produces uterine contractions. Now, we use this medicine all the time in obstetrics, for cervical ripening, for induction of labor, for controlling postpartum hemorrhage. Its side effects, normal side effects, are nausea, vomiting, diarrhea, headaches, dizziness, fever, chills, and hot flushes. So again, misoprostol is the second medication in this regimen. Now, misoprostol is teratogenic. The first medicine, mifepristone, is not known to have any birth defects, but the second medication, misoprostol, is teratogenic. This is important if the woman still has a live pregnancy. So it has been associated with Mobius sequence, which is facial or Dussen's nerve palsy, central hypoventilation, and terminal transverse limb defects. And this is felt to be due to disruption of the fetal vasculature. So I'm going to go into some studies on complications of chemical abortion. Just as an overview, so I'm going to first talk about the studies here in the United States, and then I'm going to talk about some international studies. They actually show some different findings. So in US studies, surgical evacuation is required about 2% of the time. Ongoing pregnancy up to half to about 1%. Transfusion up to about 0.1%. ER visits have been seen in about 3 to 4% of patients. Hospitalization less than 1%. And infection, serious infection, and ectopic pregnancy are very low. So in this first study, I'm going to talk about, this was a systematic review where the authors looked at 20 studies, so over 33,000 patients. They found that ongoing pregnancy occurred in 0.8%, so almost 1% of the time. Now that was up to 63 days gestation, which is 9 weeks. Interestingly, in the studies that looked at, that 9 to 10 week period from 64 to 70 days, it happened in almost 3%. As I mentioned, it's less effective and higher complications the farther along in pregnancy. The efficacy, meaning how likely to cause abortion, 96.7%. However, in the 9 to 10 week period, 93%. Transfusion was under 1%, ER visits 3 to 4, hospitalization less than 1%, and surgical evacuation about 2 to 4%. Now, some limitations of this study. This was a systematic review, but 3/4 of the information was from 2 large studies, both retrospective, one by Gatter and one by Goldstone. And as you can see, these studies had a 15 to 17% loss to follow-up. The one study didn't look at all at the ER visits, and the second study didn't look at hospitalization or ER visits, which of course brings into question if we're missing data here. This is a study, another systematic review by Raymond. The authors looked at 87 trials, 45,000 chemical abortions, and they found that the efficacy was 95%. Ongoing pregnancy was 1.1%. Transfusion and hospitalization was low. Now, in this study, efficacy would mean they do not need to have a surgical completion. Okay. So in this systematic review, most were small studies. There were only 7 that had more than 1,000 patients. And of course, various doses and routes of medication, which can be hard to compare. And still, almost 5% of women required surgical completion. And I will note, unless I state otherwise, in these studies, I'm talking about first trimester. Now, this was another study, a cohort study comparing chemical to surgical abortion. They looked at efficacy, 13,000 medical abortions, chemical abortions. Efficacy was 99.6%. Ongoing pregnancy was 0.4%. Surgical aspiration, 2.2%. So they are actually defining efficacy differently because they're not including they're not excluding those that required surgical aspiration. Major complications were low, and persistent pain, bleeding, or both, and any adverse event about 2%. So again, in this study, I mentioned the efficacy issue. The 16% were lost to follow-up. And interestingly, those lost to follow-up were assumed to have had an uncomplicated complete abortion. So they weren't excluded, they were assumed to not have complications. And despite this, chemical abortion had 4 times the risk of failure compared to surgical abortion. And ongoing pregnancy increased by 50% for each week of gestation. This is a study by Cleland. They looked at all of the chemical abortions performed by Planned Parenthood in a 2-year period. So this was over 200,000. Now, they only looked at 8 specific complications that are listed here. And you can see, I won't go through these numbers, but you can see that the complications they list are very low. And their conclusion was the overall complication is 0.65%. However, this was only the complication of these particular 8 complications, and they did not include the most common complications: retained products of conception, hemorrhage without transfusion. They didn't include incomplete abortion if it was treated at the abortion clinic. Interestingly, they can only report the data they know. So if a woman, they can only report the data reported to or received by Planned Parenthood. So if a woman goes to the emergency room for her treatment, which many women here do, then the authors of this study would not be able to report that. And they also did not disclose the percent loss to follow-up. So just as a summary, there are some limitations, I believe, with US studies. In this country, there's no federal tracking of abortions. There's some big issues with the adverse event reporting system. Abortion providers are not required to report any complications anymore, except death. And there's often a significant loss to follow-up. And we know from other studies that most patients here do not follow up with their abortion provider if they have complications. They usually go to the emergency room. Now, also in some studies, I didn't go over this detail, but women have an ultrasound, which is great. They should have an ultrasound to determine how far along she is and where the pregnancy is. But in real life, an ultrasound is not required here. So that's an issue. Also here in the United States, patients are often told to tell the emergency room that they're having a miscarriage, not an abortion. So those complications may not be recognized as an abortion complication. And as I had mentioned also, some studies that look at complications often exclude certain complications. Oh, one more US study. This is actually, because we're going to talk about self-managed abortion. And of course, the kind of precursor to that is telemedicine abortion. This was another US study done by Raymond in 2019. In this study, the patient had a video conference with a healthcare provider. They had a pre-abortion ultrasound and they had lab tests. So they were sent by mail. The abortion pills, 248 packages were sent by mail. And then they followed up with their healthcare provider by phone or video. The author's conclusion from this study, this direct-to-patient telemedicine abortion service was safe, effective, efficient, and satisfactory. Let me tell you about the details of this study. In this study, 23% of patients had unknown outcome. 7% of those with known outcome needed surgical completion. 2 of those decided to continue the pregnancy, so they didn't take the second drug. And 31% of those who had an Rh negative blood type did not receive RhoGAM, Rh immune globulin. 8% went to the emergency room, and 1% had a serious adverse event. So now I want to talk about some international studies. Some other countries have better tracking systems. And so I believe they may have better data. This is a study out of Sweden by Carlson, where they looked at all abortions, so both chemical and surgical abortions at a certain hospital. And 3/4 of those were chemical abortion under 12 weeks. In this study, all patients had a pre-abortion evaluation. They had a gynecologist visit at the clinic. They had a pelvic exam. They had an ultrasound, and they were screened for infection. All good things expected to decrease complications. They found that for chemical abortion under 12 weeks, 4% had an incomplete abortion. The overall complication rate was 7.3%. And interestingly, over the time period of the study, from 2008 to 2015, complications increased from 4.2 to 8.2%. And the reason for that is not clear, but I just point that out. This is a study by Niinimäki out of Finland. Now, Finland has a national health registry where they would have records of all the abortions. So they looked at all women in Finland undergoing abortions of both types over a 6-year period. So this was 42,000, almost 43,000 women. And they looked at abortions up to 9 weeks or less. And then they followed them for 6 weeks post-abortion. What they found in this study This is a little busy graph, but you can see the purple, the light purple is chemical abortion, and the light yellow is surgical abortion. Women with any adverse event, 20% of those undergoing chemical abortion, compared to about 6% for surgical. Hemorrhage was almost 16% compared to 2% for surgical. Incomplete abortion was almost 7%. Surgical evacuation required in about 6% compared to about 2%. And infection was the same in both. So again, just to summarize Ninamaki's study, 20% of women who underwent a chemical abortion had at least one adverse event. 15 out of 100 hemorrhaged, 7 out of 100 had retained tissue, 6 out of 100 needed emergency surgery. Again, this is the first trimester. So there's a lot of push here in my country about how safe chemical abortion is, it's how safe it is to manage your own abortion. But the bottom line is there are significant risks. And in fact, it's much less safe than a surgical abortion. And here are some other studies pointing this out. Compared to surgical abortion, here's just 4 studies. The one I just talked about, chemical abortion, 4 times the risk of complications. Another study by Upadhyay, 6 times the risk of complications. The study by Ireland, 4 times the risk of failure. And a study by Stednicki, more than 2 times as likely to result in an abortion-related emergency room visit. This is chemical abortion compared to surgical abortion. We also know that risks increase with gestational age. Again, another study out of Finland by Mantula, looking at about 18,000 women. In the first trimester, surgical evacuation was required in about 8%, 7.9%. In the second trimester, this went up to 38.5%. Likewise, infection was higher in the second trimester. It was 4% compared to 1.9% in the first trimester. I want to talk very briefly about chemical abortion with misoprostol alone. So with the legal climate here, people are looking into other options. And also misoprostol, I would imagine in some of your countries is much easier to get than mifepristone. So women may be using this alone for abortion. In this study looking at the efficacy of misoprostol alone, this was a study by Raymond, 22% had failure requiring surgical completion, 6% had an ongoing pregnancy, so much higher than the drug combination. And this study out of Vietnam, which was a double-blinded randomized controlled trial looking at women up to 63 days gestation. So if they had 400 women randomized to receive either misoprostol alone, 2 doses, or mifepristone and misoprostol. And in the misoprostol alone group, complete abortion in 76% compared to almost 97% in the group that took both drugs. Ongoing pregnancy was 16.6% compared to 1.5%. And they noted that the side effects were similar, although there was more diarrhea in the misoprostol alone group. Now, I know I'm going to talk a little bit about obtaining abortion pills online. I know this may vary in countries, but, and I know in many countries, a woman can just walk into a pharmacy and buy medications. But I just want to show you, I only have a few up here, but it is extremely easy to buy the abortion pill online. Multiple sites, a woman can go in and just order it. Some of these sites may require information like their last menstrual period, but these pills are, it's not necessarily legal, it's not legal, but it is available. And interestingly, this is a study where they looked at women who obtained pills from the internet, and they looked at the quality of the pills. So they ordered these pills online. So out of 22 orders, they only received 20. And the mifepristone which was 200 milligrams, all of the medicines were within 8% of that dosage. But the misoprostol, 200 micrograms, some had only as low as 17% of the drug in the pill. Only 30% of the pills had the drug within 10% of labeled doses. 6 of 20 of the packages had a pinprick, and 1 out of 20 had extensive damage to the package. So the other issue with women obtaining these pills online is, what are they even getting the medicines they think they're getting. But I do want to talk a bit about self-managed abortion, chemical abortion. So whether the women obtain the pills online, or she walks into a pharmacy and buys them, when women manage their own abortion, there are particular complications. So I mentioned some complications, and I would like to just point out that those are the tip of the iceberg compared to women managing their own abortion. This is a busy slide, but we're going to review these. So one issue is how far along she is, estimation of gestational age. Now, some of these sites will ask a woman when her last menstrual period is. And women don't always know, or if they know, it might be inaccurate. And that's how they determine gestational age. Also, if you put in a last menstrual period that shows you're too far along, some sites will tell you that, and then you can just go back and change it. So if somebody really wants these medicines, they can get around it. And as we know, self-reported last menstrual period is not always accurate. In one study, 40% of women have their due date adjusted because of a discrepancy with ultrasound. And as I had mentioned before, complications increase with increasing gestational age. So if a woman takes these pills thinking that she is 8 weeks, but she's really 18 weeks, there's even going to be further risk to her. I do want to talk about ectopic pregnancy. As I mentioned, it's not caused by these pills, but neither is it treated by these pills. So if a woman has an ectopic pregnancy, but doesn't know it and takes these medications, and this is one of the reasons why it is so, I'm not advocating abortion, but if women are going to get abortion, they should be getting an ultrasound. It's not required here. Ectopic pregnancy is about 2% of all reported pregnancies, about 2.7% of pregnancy-related deaths, and half of women with ectopic pregnancies don't have risk factors. Some of these online sites will ask some questions, but half of women don't have risk factors. And the early symptoms of ectopic pregnancy, pain and bleeding, might be easily attributed to the abortion process. In my country, there have been 2 deaths from ectopic pregnancy, ruptured ectopic pregnancy in women taking chemical abortion pills because they didn't know their pregnancy was in the tube. Another issue is Rh status. If women are Rh negative, they should be receiving Rh immune globulin in any pregnancy to prevent problems in a future pregnancy. About 5 to 15% of women are Rh negative. And the risk of alloimmunization of forming antibodies, if not treated, is about 13 to 16%. And that is so much lower with Rogan. So the problem, obviously, with women self-managing their abortion is, are these women who are Rh negative receiving Rogan? Probably not. And we know that untreated isoimmunized infants, 14% are stillborn. And if they are born alive, half die in the neonatal period or have brain injury. Even ACOG says Rh immune globulin should be given to Rh negative women who have pregnancy termination, either medical or surgical. Now, there is a push here to try to say that's not necessary. I don't think we have that science, and I think it's not right for women. The other issue is who will care for the complications if she's not seeing a doctor to get the abortion. when she has complications, does she even have a doctor to go to? A little bit on abortion and human trafficking. We do know, terrible situation, these poor trafficked women, but they are having abortions. In this study, where Dr. Lederer surveyed human trafficking survivors, she found that 55% had at least one abortion and 30% had multiple abortions. And trafficked women are having forced abortions. In this study, 53% had one or more abortions, partly or wholly forced on them. One victim said, "In most of my 6 abortions, I was under serious pressure from my pimps to abort the babies." Another victim reported 17 abortions and indicated that at least some were forced on her. The reason this is relevant to the chemical abortion issue is these are just so much easier to get. Now, with a surgical abortion, the pimp would have to take the woman to a healthcare provider, and sometimes that's their only exposure to possibly get out of the terrible situation they're in. But now there could be forced abortions with pills. Trafficked women, they do present to abortion clinics. 88% had contact with a healthcare provider while being trafficked. 30% had visited Planned Parenthood. 68% identified a clinic as the site of their abortion. I think what's going to happen is that these women will just be given pills and not even be taken to a physician. And on the same note, reproductive coercion, these are just a few examples, but these are, where men have forced abortion. This man spiked his girlfriend's smoothie with mifepristone and was sentenced to 22 years in prison. And this is a doctor in Virginia who put mifepristone in his girlfriend's tea, resulting in death of the fetus, and he pled guilty to fetal homicide. Just in closing, I want to talk very briefly about what's called abortion pill reversal. So what if a woman changes her mind after taking mifepristone? So she takes the first pill, she hasn't taken the second pill, and she regrets her decision, and this does happen. Well, this is a study by Delgado and some others, and there have been some other studies, but this was the case series of 754 women who changed their mind after mifepristone, and the eligibility was within 72 hours of taking. They were within 72 hours of taking mifepristone and hadn't taken misoprostol. There were 547 eligible women. They were given various doses of progesterone, and they found that high dose progesterone had intramuscularly had a reversal success of 64%, and high dose oral progesterone at 68%. Now this study and this intervention is highly criticized by country by pro-abortion people. They say that it's not good science, and the fact is that we know that progesterone is safe in pregnancy, and it's been widely used in pregnancy. And again, if you look at these numbers, this is a case series, it's not a randomized controlled trial, but if you compare it to mifepristone alone, so if the woman takes the first pill, doesn't take the second pill, but doesn't take progesterone, that survival of the baby is about 25%. There have been thousands of babies saved from abortion pill reversal. So I just want to close. I want to thank you so much for your kind attention. I'm going to address some questions, but just want to close with this proverb: deliver those who are being taken away to death, and those who are staggering to slaughter, oh, hold them back. Proverbs 21:11. Thank you so much.
Chris, thank you so much for sharing all that. There's some quite shocking statistics and data in that, and you've given us a wealth of information. And so thank you for your time. Before I ask the first one that's come up, I will just comment. One of your first slides that you showed is just the amount of medical abortions or chemical abortions that are taking place in the States now, and that most are. And actually, I'm in the UK, and I was pretty shocked. The most recent statistics in Scotland show that 99% of all abortions are medical abortions, 99%, slightly less in England and Wales. But I was quite shocked by that. It's basically every single abortion now takes place using the pills. So this is an incredibly topical subject. That's, as you've shown clearly on one of your initial graphs, is the direction of travel now with abortions. And so I think it's incredibly prescient that you and others are doing more work on this. And I think it's really important that more people understand what's going on and some of the dangers that you've highlighted in that. So thank you for that. Yeah, I'm going to ask some of the questions that have come in. So the first one from Dave Crick, he asks, are there other large studies like the one that you mentioned in Finland, where the women are followed up for 6 weeks, thus giving a much more accurate assessment of complications?
Are there other large studies? I'm not sure what the question, there's lots of studies going on all the time, obviously, and each study has to be looked at individually. What we'd really like to see here, what I'd like to see in my country is that all abortions are tracked. Let's find out. But the other side doesn't want to really know those complications. I don't think. Yeah, I would hope that countries like Finland and those, of course, there is a publication bias and like that. Now that study was not published by those people, or they say are pro-abortion, and they just presented their data. Yeah, but hopefully we will have more information. I don't know, but thank you for the question.
Yeah, and just on a follow-up on that, are you aware of any ongoing or new studies on this? And on that, clearly there will be many done by those who are more pro-abortion, but I just wonder, are you aware of any that are done by some who would be less biased, or perhaps those who are done by people who are perhaps more pro-life as well?
Oh yeah,
we're aware of others, but if there are one coming up to be aware of.
Certainly studies going on all the time. I work with a research group. We've published some papers with, if you look up Dr. James Studnicki, Studnicki, some important studies there, showing the higher rate of mental health, higher rate of emergency room visits. Definitely, yes.
You mentioned that, sorry, I have seen some other questions come in, but let me just quickly follow on. I have a burning question as well, which actually you hinted at there. So I'm just going to take prerogative and ask you, are you aware of any research that's done on the psychological or emotional effects of medical abortion? Because I know that from my own work, it's certainly 5 years ago, I could find very little research, but I could get testimonies, so stories from people which were quite shocking. And I just wonder if there's any research that's been done.
Yes, thank you for that question. Well, there is research. Again, there's, people who are pro-abortion point to a study, the Turnaway study, and claim that, see, these women who were denied abortion had worse outcomes mentally. But they don't tell you the downfall of that study, where there was just a very low follow-through rate, and then there have been many other studies showing that there are adverse mental health effects from women undergoing abortion. Again, we have the problem sometimes is publication bias, and a study can be a bad study and is touted as see, this is what it shows, but not everyone, we need to look at the data objectively. I will say, and I, just like you said, Philip, I mean, this is anecdotal, but as a physician, when women come into my office, and, I always take an obstetric history. How many pregnancies have you had? how many live births, how many preterm births, how many miscarriages, how many abortions. And almost invariably, when I ask them, they talk about abortion, you can see the downcast in their countenance. So I personally have no doubt that there is a significant effect there.
Yeah, I mean, I'd agree from the anecdotal ones. I think it's probably even worse than the surgical abortions, because women are doing them at home, they're taking responsibility, they're seeing the product of it, I think, and in the comfort and safety of their own home. So I agree. A couple of points from Margaret Eames. She's just comments that in the UK, home medical abortion was made legal and routine in April 2022. That's during the COVID time, but only with 1 week's notice and without scrutiny of evidence-based medicine. So complete lack of scrutiny in it.
Well, and I heard, am I correct that after that was made legal, that then there were some reports of women, being rushed to hospital, being 30 weeks, or, I don't know that I have the specific data on hand, but I believe there were some significant complications after that. I don't know, maybe someone in the country could.
Yeah, I mean, she goes on to say in the Q&A, Margaret, and I know she's done a lot of work on this, so she's quite an expert on it. She says she's got freedom of information data showing that during COVID, during 1 year, over 7,400 women in England had to go to accident and emergency for complications of home medical abortion, including extrasurgical abortion. So she's trying to get numbers on the forms just to get a follow-up with the records that are kept on it, on the abortion forms, to try and track these after effects. And she's just saying, can she collaborate? I mean, Margaret knows a lot about the statistics, and I mean, 7,400 women A&E after complications, that's shocking. And she's making a final comment that this kind of stuff, and it will be the same with you. And actually that leads on to another question that I kind of like to ask, or a direction, is, she's saying we need to bring that to Parliament, this kind of information. And it comes back to what you were saying earlier about scrutiny over this and recording. And it's just, the question is how, if people are on the advocacy campaigning side, what can we do about this? Is there any way that we can use this data? Can we get any of this to Parliament? So our UK government. And that leads to a question I think probably others may have, is what do we do about it? Is there anything we can do it from a kind of advocacy perspective? Can we use this data?
Well, the problem is in my country, we don't have good data, and the other side is saying this is good data. I wish we could, I think 20 or 30 years ago, you used to be able to agree to disagree and work together. But what's happening now is people who are pro-abortion, you would think that everybody would want to know, if we're giving these medicines to women, what are the real complications? Like, let's just know that would be the right thing. No matter what your opinion on abortion is, that would be the right thing for women, to be able to track all abortions, to track all complications. To have that kind of system in my country would be so important. And that is, I would say, near impossible to make that happen because of the other side not being willing to, that's my understanding.
Yeah, no, I think I would concur. And certainly in the UK, if we go down the route of changing the law and what we call decriminalizing it, so completely changing the law, it'd go down to regulations, and the data and the tracking would be far worse than we've even got at the moment, which is why the Finnish data you cited is really helpful, particularly helpful. Right. But there's a question from Claudia Stein. She says, if countries employ electronic prescription, they could systematically track the use of this medication, even though there will always be a black market. Is there any move towards that in the US?
There is no move towards that, as I mentioned. I don't think that, again, I think it would be very important to track that, well, how many abortions were there and what were the complications? And that's not being tracked. And I think there is probably some big pushback to doing that, unfortunately. But I mean, that's a great, that would be a great way to do it. Yeah. So
Yeah.
to follow these women, but that's why, again, the data from Finland and other studies that have linkage data that can link complications to the woman that had the abortion is important.
Yeah, and that's one of the things that Margaret, in effect, is wanting to try and do, is just see if we can get it linked, because we know from what studies there are that there will be many more complications. So, how do we make how do we get this information out? So, how do we get women to be more aware of the risks before they make a decision on this? Are there ways that we can get this information out to women who are considering having a termination?
Right. Well, I mean, there's, obviously many routes to do that. I think anyone on this call has probably taken that step by getting information. We need to, know the information ourselves. We need to let women know. Yeah. And again, the misunderstanding is that chemical abortion is safer than surgical abortion. It's not. And that, safe, you can have a safe abortion at home, and it's not. And we need to really continue to work in any way we can to make women and healthcare providers aware of this. I think it's important for emergency room providers to know this, because they are seeing women come in, and women are actually told not to tell them they had an abortion, but to tell them a miscarriage. And there's different risks. So we just unfortunately recently had a death in the United States from chemical abortion from infection. A woman died, and a young woman. So yeah, it's important to get this information.
Yeah, I remember reading things put out, information put out by organizations like Women on the Waves, who really promote pills by post, we call it over here, actually, and just would say, if you have any complications, say you've had a miscarriage.
Right.
Blatant in it, to just don't say anything about having a termination. It's all about miscarriage. And so it completely skews all the data. I've got another question also about the impact that medical abortions will have on developing countries, because most of the data you've cited is obviously where we've got it from, our sort of more the Western developed countries, and where we've got the data collection. But we know, I mean, it's obvious, and you'll probably have particular experience of this, having spent so much time in Bangladesh, the impact of this on developing countries, the impact of chemical abortion on women in developing countries would surely be so much worse if there's poor or less accessibility to good medical care, if the sanitation, water and all of that is not as good. You can see what the risk of infection and bleeding there would be like. Is there any information at all on women in developing countries using this? And do you think that it is a problem, the direction of travel for developing countries, this issue?
I think it is a big problem. I think that is a great point, because if women can access these pills, and as we know, in many countries they can walk into a pharmacy, and you can't do that in the United States. You can't buy these yourself, but I would imagine in almost all countries you can either walk into a pharmacy or buy these online. And then especially in third world countries where women are not near a facility, a healthcare facility. So, the big concern here is the hemorrhage, women hemorrhaging, and they're not near a facility that can either give them a blood transfusion or a DNC. It's quite problematic. Yes. Thank you. That's a very good point. And that's why I brought up wanted to mention the misoprostol alone, because I think that there may be more of that as well, because that drug is more accessible than mifepristone. So then your bleeding complications are going to be even higher.
Someone's raised a point about a case we had in the UK, someone called Carla Foster, who hit the headlines. She was actually put in prison for a short while, but she basically took the pills in a late pregnancy, and our overseeing body, the Royal College of Obstetricians and Gynecologists, knew it, But they certainly weren't put in the doc. So the ones who know about this and who supply the pills are not the ones who are put in the doc. It's the women who unknowingly, often, presumably mostly unknowingly, take these pills, not realizing the dangers of them, especially, and hers was a case where this point that you made about the importance of gestation was an issue, because she took them so late in her gestation. And that is a massive problem, I think, is that women not knowing what their gestation is and not realizing the dangers of this for a later gestation. But this point is really about the responsibility here, I think, is a really important point. We've got to sometimes be careful not to blame the women all the time who aren't informed on this and who are vulnerable and not in a good place, and they don't know how to make a decision, and they're told by people they trust that this is safe, and it's not. And I think we've just got to, as this point is made, I think we've got to remember that the blame should lie with those who are supplying it, with those who are overseeing it, in our case, our obstetrician and gynecologist body, and government. That's where the blame mostly should lie, not necessarily. We are too quick often to blame the women.
Yeah, that's a great point. It's just tragic. And yeah, thank you for whoever pointed that out about the situation in the UK with that woman. So she's in prison for infanticide, yet it's okay to kill the baby earlier.
Yes, and to supply the pills. It's not the suppliers that are in the doc. So just one very quick question before we end. Do you have any sort of anything positive or optimism, or any hope for the future in any way, or sort of some sort of things that you can encourage us to do out of this?
And that's why I ended the presentation with the abortion pill reversal. There have been thousands of babies saved by this. There are women who take the first pill and regret it, and high dose progesterone. And there is a site called abortionpillreversal.com that, if someone's interested, they could probably get more information on details there. But for a woman here who wants to reverse her abortion, she can call this hotline and get connected with doctors that prescribe the progesterone. And so, yeah, that's why I think again, it's being criticized, but it's a great thing that if women have changed their mind, there is some hope to reverse the effects of mifepristone.
Yeah, no, that's really helpful. Thank you. And we've got a lovely doctor here as well, who's had some legal challenges, but again, has saved a lot of babies through that. But I need to draw this to a conclusion now and close. And just thank you so much for your wisdom and for your time and all the research and the work that you've done. We've had a really fascinating hour with you, and we've learned a lot and been given lots of challenges. So thank you for joining. God bless you all, and hopefully see you on another webinar. Okay, bye.
Everyone.